Derm pathology, vascular tumors of the skin, and skin infections. So first we have vascular tumors of the skin. We're going to start off with angiosarcoma. Angiosarcoma is a rare blood vessel malignancy, okay? And it's associated with, its common association is with chronic post-mastectomy lymphedema, okay? So if you see like radiation therapy and chronic post-mastectomy lymphedema, that is going to be your association with angiosarcoma. All right, that's pretty much all I would take away from this. Next is going to be bacillary angiomatosis. Bacillary angiomatosis has its association with patients who are immunocompromised, specifically with AIDS. It's caused by Bartonella henselae, which is our Bartonella infection, obviously that causes cat scratch disease. But if patients that receive Bartonella are immunocompromised with AIDS, they will present with bacillary angiomatosis, okay? And it's often mistaken for Kaposi sarcoma. Remember, this bacillary angiomatosis is caused by Bartonella, so it will have a neutrophilic infiltrate because it's bacterial. Whereas Kaposi sarcoma, which we'll discuss later on, actually might as well just go at it right now. Kaposi sarcoma is going to have a lymphocytic infiltrate because it's associated with HHV8 and HIV, which are viruses, okay? And Kaposi sarcoma is derived from endothelial cells because it's an endothelial malignancy. It usually is going to affect the skin, the mouth, the GI tract, and respiratory tract. And what they want you to know is that it's classically seen in older Eastern European males. Also associated with patients with AIDS, obviously, as we discussed previously, for immunocompetent patients versus immunocompromised, Kaposi sarcoma is going to be seen in immunocompromised as well as bacillary angiomatosis, okay? Its association is highly associated with the herpes virus 8, HHV8, and HIV. And remember, lymphocytic infiltrate compared to bacillary angiomatosis, which is caused by bacteria, Bartonella, which will have neutrophilic infiltrate. Next is going to be our cherry angioma versus our strawberry hemangioma. The cherry angioma is going to be commonly appearing in middle-aged adults, okay? It will not regress, and it usually frequency is increased with increase in age, okay? It's benign capillary hemangioma, and it's seen in adults. That does not regress. That's the key takeaways for cherry angioma. For strawberry hemangioma, this is going to be seen in infants, okay? And once again, it's very similar. It's a benign capillary hemangioma, but it's seen in infancy, the first few weeks of life. What's going to happen, it's going to grow rapidly, and then it's going to regress spontaneously, usually by the age of 5 to 8 years old. Okay, so strawberry hemangioma is going to be spontaneous resolution, whereas cherry angioma cannot. Okay, it cannot resolve or regress spontaneously. Cherry is in adults, strawberry is in infants. Those are the key takeaways there. Lastly is going to be our glomus tumor. Glomus tumor is going to be a benign, painful, red, bluish tumor that's underneath the fingernail. So if you see a red, bluish tumor underneath the fingernail that is kind of affected, painful when exposed to cold air. So it has thermoregulatory glomus body. So that means that it's going to be affected when exposed to different temperatures, specifically cold. It's going to become painful when cold. That's because of its thermoregulatory glomus body. All right. And it arises from modified smooth muscle cells. So key takeaway for glomus tumor is it's found underneath the fingernail. It's a red blue tumor that's made up of smooth muscle cells of the thermoregulatory glomus body that is painful when exposed to cold air. All right. So that's pretty much all of the things that you need to know. There's one more, which is pyogenic granuloma, not high yield at all, but just for kind of completeness, it's associated with trauma and pregnancy. And what you'll see is like capillary hemangioma that can ulcerate and bleed. Once again, very, very low yield. All right. Next is going to be our skin infections. Skin infections are going to be separated via bacterial and viral. First one is going to be bacterial. We'll talk about impetigo. So impetigo is a skin infection that involves the superficial epidermis. Now for impetigo, you usually will see Staph aureus or Strep pyogenes group A strep that are highly associated. It's very, very contagious. And what they want you to know is you'll see honey-colored crusting. Honey-colored crusting is key to impetigo. If you see honey-colored crusting, you know it's impetigo. There's also another association with bullous impetigo, which turns into bulla, okay? And it usually is caused by Staph aureus, okay? And what you'll see is that Staph aureus causes bullous because it cleaves desmoglein in kids. And that's what causes the bullous formation in bullous impetigo. So Staph aureus is going to cleave desmoglein, and that's what causes the bulla seen in bullous impetigo. Next is erysipelas. Erysipelas is an infection involving the upper dermis and superficial lymphatics. What you want to know is that it's caused by Strep pyogenes, another group A strep. And is going to be well-defined raised demarcation between the infected and normal skin. And what you want to know about erysipelas is that it's well-defined and raised demarcation. You can know exactly where the location is in erysipelas. And we want to compare that to cellulitis because cellulitis is not clearly demarcated. It's not clearly demarcated at all. And so that's the difference between erysipelas and cellulitis that you have to take away. All right. And cellulitis is going to be acute, painful spreading of infection of the deeper dermis. and subcutaneous tissue, whereas erysipelas, remember, is the upper dermis and superficial lymphatics, okay? So the way that I remembered it is up in the air, so erysipelas, up, upper dermis. So up in the air, erysipelas. Cellulitis is down in the cell, so you're like trapped down in a cell. That's going to be infection of the deeper dermis and subcutaneous tissue. And remember, very, very, very important that it's not clearly demarcated compared to erysipelas, which is clearly demarcated, okay? Now, cellulitis is also caused, usually often starting with a break in the skin from trauma or like another infection, right? And it's caused by almost always our Strep pyogenes and Staph aureus, right? Next is abscess. Abscess is a collection of pus, usually within the deeper layers of the skin, and it's almost always Staph aureus. Next is necrotizing fasciitis. This is very scary. The patient's usually going to present with a minor skin trauma or diabetic or immunocompromised patient after surgery. They're going to present with redness, severe pain out of proportion to presentation of physical exam, and they could be feverish or hypotensive. And that's going to be signs of necrotizing fasciitis. Pain out of proportion to physical exam is very high yield for necrotizing fasciitis. Remember, this is an emergency, usually caused by anaerobic bacteria or Strep pyogenes, and you can see crepitus from methane or CO2 producing bacteria. So that's going to be associated with necrotizing fasciitis if you see crepitus. It's surgical emergency. You have to take them back to surgery and debride the area, okay, because it could cause skin necrosis. Lastly, for our bacterial infections is a staphylococcal scalded skin syndrome. This is found in the sketchy. What you're going to see is an exotoxin destroying keratinocyte attachments in the stratum granulosum only. This is very high yield. It's stratum granulosum only. It's an exotoxin mediated stratum granulosum or skin damage. Okay, they want you to know that it's exotoxin as well. All right, and the patient usually is going to present with a fever and generalized erythematous rash that causes like sloughing of the upper layers of the epidermis. It heals normally completely. Okay, so staphylococcal scalded syndrome, although it looks scary and it's like this patient, it looks like they're sloughing of their skin completely, but it's only sloughing of the upper layers of the epidermis. Okay, and that's pretty much already dead tissue, so it doesn't really matter and it will heal completely. Now, it will have a positive Nikolsky sign, which is just separation of the epidermis when you like slightly stroke the skin, okay? So this is our bacterial infections. Next is going to be our viral infections. First, we have herpes. Herpes is going to be HSV1 and HSV2, and it can occur anywhere from mucosal surfaces to normal skin, right? This is going to include herpes labialis, which is on the lips, herpes genitalis, which is on the genitals, obviously, and that's HSV1 and HSV2, respectively, and then herpetic whitlow, which is on the finger, usually seen in dentists because they have their fingers in people's mouths all the time. Next is molluscum contagiosum. If you ever see umbilicated papules, they're talking about molluscum contagiosum. They will call it umbilicated, firm, dome-shaped, flesh-colored papules. If you see that, it's caused by pox virus. It's molluscum contagiosum, okay? Very, very easy to see. Firm, dome-shaped, umbilicated papules that are flesh-colored. Next is varicella zoster. Varicella zoster is going to be obviously the causes varicella, chickenpox, and zoster, which is shingles, and it's going to present in like, first off, if it's varicella, it's going to present in multiple crops of lesions, which is chickenpox, and they're going to be in various stages of healing. So they could be vesicles to crusts. So remember, various stages of healing is very high yield. Zoster is a reactivation of the virus, which normally stays, remember, in our dorsal root ganglia, and it's going to be presenting in a dermatomal distribution. So it's going to be severely painful, and it's going to be presenting in a dermatomal distribution, which is zoster or shingles. You're going to see multinucleated cells with intranuclear inclusions. That kind of gives you the hint for zinc smear that is going to be varicella zoster. And lastly is hairuloplakia. Hairuloplakia is irregular white painless plaques on the lateral tongue that cannot be scraped off. And it's highly associated with EBV. Okay, it usually occurs in patients living with HIV. And what you need to know, once again, is that in contrast to thrush, leukoplakia cannot be scraped off, and it is precancerous, whereas thrush is scrapable. Lastly, for this section is going to be the cutaneous mycoses, okay? So this is going to be our issues caused by, our cutaneous issues or skin infections caused by fungi. What they want you to know specifically, the highest yield thing is going to be tinea, okay? Tinea is dermatophytes, okay? That's another word for tinea. And tinea or dermatophytes, the clinical names for them are dermatophytes, cutaneous fungal infections, okay? And what they usually infect, the infection is usually limited to the keratinized structures only. So only the areas of the skin that are keratinized will be infected with tinea or with fungal infections, okay? Now, the dermatophytes include microsporium, trichophyton, and epidermophyton. The most important and highest yield one is microsporium, all right? Microsporum. And what you're going to see is branching septate hyphae, which are visible on KOH prep, all right? And it's highly associated with pruritus, so it's going to be a very itchy infection. Tinea is very itchy. Now, There could be different presentations on where they present on the body. You have tinea capitis, tinea corporis, tinea cruris, and tinea pedis. First is tinea capitis, which occurs on the head and the scalp. What you're going to see is essentially alopecia and scaling. Look at a photo of tinea capitis. That's something that they like to show on exams for it to be tinea capitis. Next, and it's going to have associated lymphedema or lymphadenopathy. Okay, very high yield to know that it has associated lymphadenopathy because it's going to be opposite from trichomania, which is where someone just pulls their hair out of their head without lymphadenopathy. This one, tinea capitis, does have lymphadenopathy with the alopecia and scaling. Next is tinea corporis. Tinea corporis is on the body, and it usually is acquired from contact with infected pets and farm animals. This is known as ringworm. Okay, so it's going to have the characteristic surrounding circular rash with a central clearing. Next is tinea cruris, which is occurring in the inguinogenital area, and this is known as jock itch. Okay, it does not show the central clearing as much as tinea corporis. Lastly is tinea pedis. Tinea pedis is going to be, actually not lastly, tinea pedis is going to be athlete's foot, okay? And lastly is going to be tinea unguum, which is going to be onychomycosis, which is just infection of the nail beds, okay, occurs on the nails. What you want to know is that you're going to treat tinea infections with terbinafine or greasephulin, as well as potential azoles, all right? Now, lastly, we have tinea or versicolor, which is known as pityriasis versicolor. I'm sure you remember this sketchy. It's caused by malassezia for fur. And what you want to know about this is that it causes degradation of lipids, okay? Produces acids that inhibit tyrosinases, all right? So you're going to see hypopigmentation and hyperpigmentation on the chest and the back. It's less pruritic than dermatophytes. And what you want to know is that it can occur usually in the summer in hot, humid weather and environments. You're going to see a spaghetti and meatball appearance on microscopy. And lastly, the treatment is selenium sulfide. All right. So that is our overall skin infections as well as vascular tumors of the skin. If you have any questions, please let me know.